Welcome back to the Sydney Innovation and Research Symposium 2019 after lunch session. We are going straight into the great debate because there's nothing better than a great debate, and we've got the most amazing topic. The topic is that clinical systems and processes are more important than experience. I'll say it again because it's not the easiest topic. Clinical systems and processes are more important than experience. Now, I relate to all of this as a patient, and I'm thinking, is that true? Do I want a highly experienced individualist who's never followed a system and process in his or her life? Or do I want someone who really believes in guidelines and has taken them on board, maybe even done some extra training in order that he or she is on top of them? Interesting. So I'll say it again. They're arguing for and against the proposition that clinical systems and processes are more important than experience. Here are the rules. 3 speakers for and against. You've probably guessed that with the layout of the room. They have 6 minutes each and a bell at 5, and then I go crazy at 6. You don't want earlier signals, do you? I don't like being interrupted. I'll just give you a bell at 5, and then you've got a minute to finish. And then at the end, we will determine the winner with the clapometer. It's an amazing piece of technology that I will introduce you to a little bit later. Ladies and gentlemen, are you ready? I need you to make a noise. Are you ready? Are you ready? Now, come on. Are you ready? Ladies and gentlemen, the first speaker for the affirmative is Associate Professor Jane Lloyd, Director of the Equity Research and Development Unit, Sydney Local Health District, Uni of New South Wales. Jane is a former Australian Youth Ambassador. She lived in the Maldives, in the capital. How do I say it? In Mali. This island is 2 kilometres long and 1 kilometre wide, and seriously has a population of 100,000 people. She doesn't even feel this room is crowded. And she taught epidemiology to nursing students. She's truly dedicated to primary care and equity. Would you please welcome Jane Lloyd?
Okay, so the brief today was that I needed to make this fun. However, I'm pretty straighty 180. I've been told that my humour's low-key. So I'm going to give you a persuasive argument. I'm going to work to my strengths, and I'm going to leave it to my esteemed and hilarious speakers in my team to be funny. So if you can bear with me. Thank you. So today our team's going to argue that systems and processes are the backbone of clinical experience. With it, we can create positive patient experience. Without it, care can be compromised. So we're not actually sure why the other team are here today. Of course, what I'm going to argue is that, of course, patient experience is important, but if we don't have the systems and processes in place to ensure we're speaking to patients who are at greatest disadvantage and risk and who are least likely to access healthcare, we won't reach those patients. My colleague, Andrew, is going to argue that, of course, clinicians' experience counts, but alone it's not sufficient. We need systems and processes in place to avoid human error. And Mary is going to argue that healthcare needs to be acceptable to patients and that patients' experience of healthcare matters, but if we let that dominate, the patient experience alone, over clinical standards and guidelines, then harm and even fraud can ensue. So in terms of a system, the healthcare system, we know about the individual patient, we know about the care team, the organisation and the environment in which we operate. And we know that healthcare is about treating people who are sick, but it's also about promoting the health of the population. And it's our job to make sure that we reach everybody who could benefit, not just those that come to our door. And when you hear the word experience, what do you think of? Do you think of patient experience? Or do you think of provider experience? Or do you even think of provider training? The dictionary, the Cambridge Dictionary, has 2 definitions. It talks about the process of getting knowledge or skill from doing, seeing or feeling things. So that suggests clinician training. The second definition is that something that happens to you that affects how you feel. So that suggests a patient experience. So the argument I'm going to put to you today is that, of course, we need processes and systems in order to provide high quality care to our patients and to promote their health. But just think about this fact. There are close to 700,000 people in our district. We can't just make up processes each time we see a patient or we want to engage with the community. And who receives the care within Sydney Local Health District? The inverse care law states that those who experience the worst health are least likely to access care. So how do we in Sydney Local Health District, how do we provide better access for those who are marginalised? Well, we've heard about that a lot yesterday in the Care in the Community Forum. We heard about providing community and primary health care services in the neighbourhood, close to where people live, in their homes, and we keep coming back. We work in partnership with non-government organisations and the Primary Health Network and universities to work towards providing care for patients throughout their journey in the system. And we help patients to navigate this system. One of the ways we do this is by checking firsthand what the experience might be. So one of the projects that the Herdu did was we went to Canterbury Hospital and we had some bilingual community networkers who met with members of the community and in language walked through the hospital to find a destination that we'd set, and we asked them about that experience in language, and we heard from those patients how welcoming Canterbury Hospital was and how the staff were very friendly, but we heard that they found it really hard to get to the grounds, to the campus itself, getting on the bus when you don't speak English. So when through Can Get Health we have tours of the hospital in language, we make sure we meet at the school or we meet at the library and we get on the bus and we show people how to get there. Another way is that we've got the Rahinian Little Local or the Lakemba Little Local, where the community themselves are given a small amount of funds and they decide on their priorities. They organise the events, they connect, and they solve their own health problems and learn those skills along the way. So the other way we do it is we've got a diverse workforce. We, in Can Get Health, employ bilingual community networkers. In Sydney Local Health District, we have targets for employing Aboriginal people in all areas, all levels of the organisation. We provide interpreting services. So we know what we need to do to improve access. We don't just do the same for everyone. We have different strategies to improve access, but we couldn't do it without systems and processes. So I will leave you with this. Systems and processes are the backbone of clinical experience. With it, we can create positive and equitable patient experience. Without it, care can be compromised. Thank you.
I put it to you, ladies and gentlemen, that Jane Lloyd not only gave us a totally cogent and coherent support for her argument, but she finished nearly a minute early. Would you please give her a round of applause? My first speaker for the negative is Associate Professor Jody Ingalls, Cardiac Genetic Counsellor, Cardiology Department RPA, Head of Clinical Cardiac Genetic Group, Molecular Cardiology Program, Centenary Institute. I sense she has something to do with the heart. Jody started working, I find this absolutely extraordinary what I'm about to say. Is this true? Jody started working at the Centenary Institute at RPA in 2003. She's worked in the district for almost 16 years. I put it to you, she has a youthful demeanour, which is a flashy way to say she looks like a lot of us want to look. Ladies and gentlemen, please welcome Jody Ingalls.
Thanks, Julie. I must admit, when I wrote that as my fun fact, I thought you'll get it anyway, it's hard to get respect when you look like you're 20, but that's fine. So I'm going to be representing the negative, and I just wanted to firstly welcome you all to the Sydney Systems and Processes Symposium. It's the real jewel in the crown of the Systems and Processes week that Sydney Local Health District run. Because you all know that systems and processes is really what drives innovation, right? And when we get those really complicated patients, as we typically do in this health service, it's the systems and processes that really stand out as what gets the best outcomes. Am I right?
Yes.
So let's start with some definitions, and so we can actually understand what we're talking about. So in the health context, what we're talking about in terms of experience is the clinician's education, training, skills, and accumulated knowledge and ability that they gain through practice. We're also talking about the patient's and the family's experiences of healthcare. And then experience is the outcome of this repeated clinical practice and research that then goes in to inform evidence-based care. Processes and systems are a series of steps taken or principles applied in a definite manner to achieve an outcome. I'm nearly falling asleep just saying it. And they're developed at a point in time based on past experience. So they're not just miraculously put together. It takes experience and research to get there. So processes and systems, sure, they're definitely important, but they're not the most important and could never alone be more important than experience. And I've got a case to illustrate my point. So let's go back to 2003 when I was about 5 years old and I was working as the first cardiac genetic counsellor in Australia and potentially one of the only cardiac genetic counsellors in the world at that point in time. And so this was a family, a lady that rang me, and it turned out in the phone call that her son had unfortunately died while out playing with his friends at the age of 16 years. The post-mortem had never identified a cause of death. So we saw this family in the clinic at Royal Prince Alfred Hospital, and the questions that she had, and all of the subsequent families ever since, are, what is the cause of death? Could I have done something to prevent this? And what about my other children? And so at that point in time, if we turned to the systems and processes, we would have had to say to this family, I'm really sorry that this has happened to you. Perhaps we could do a few ECGs, but that's about it, because nothing existed and people didn't know about this. But that's not what we did. We learned through seeing many, many families, and we developed a program based around the clinical, so knowing what tests we should be offering the families, setting up a process so that forensic pathology can direct these families directly to us. The genetics, so perfecting the molecular autopsy, which is where we take DNA from post-mortem tissue and do genetic testing. And not just that, but also the psychosocial. So, there can be lots of impact to the family. So how can we best support these families going forward? And so we've spent, 16 years working on this as a research program. And two of the really key studies that I just wanted to highlight are these. So we've shown in the only prospective nationwide study of sudden cardiac death in the young that the most common cause found in 1 to 35-year-olds is no cause. So this is, potentially a child or a young adult who dies suddenly, no previous diagnosis, a post-mortem is done, and there's nothing found. Nothing wrong except the fact that they're deceased. So that's obviously really difficult. And the other study that we did was looking at the psychological impact, because we never meet the patients in this setting. We never meet the person. We meet the family members. So we did a study asking what's the psychological impact of the family members, and we found that 1 in 2, this is on average 6 years after the death, 1 in 2 report clinically significant symptoms of of post-traumatic stress and prolonged grief. So all families need a clinical psychologist. And so as you can see, we've spent a lot of time developing the evidence base, doing the research, seeing the families, and through our expertise, we've put that into guidelines and protocols and systems and processes. So great, no, that's really great. We've got, all of the information now. So if we were seeing this family now, we'd get it right. But no, we wouldn't, because in fact, genetic testing is not routinely available for most families. Mostly it's done through research programs, so it wouldn't be. But also, even if we were to do genetic testing, what we found, the answer for this family was in a gene that's not routinely included. We're currently in the process of writing this up and adding to the evidence. So for this family, we now know why they died. We know that the parents don't carry that genetic cause, and we know what the cause of the death is. We know that there's nothing that the family could have done, and we know that the children don't have any risk. So we've given answers, not through systems and processes, but through experience and hard work and research. And so for any of us working in these areas where we're completely immersed in something and we want to provide this information to everyone else, you have to be curious. You have to not accept anything that we think that we know as truth. We have to be prepared to revise this always, because then we can better understand what these medical conditions mean. And we need to teach others. And this is the team that, when I'm saying we, this is the royal we, this is our team. Thank you.
Woo! Okay, affirmative team, you are faced with a very cogent representation of the fact that life is a complete mystery and it requires curiosity and innovation, and that she has, of course, the elixir of eternal youth. Our second speaker for the affirmative, I trust this guy, is arguing for the proposition that clinical systems and processes are more important than experience. He's Professor Andrew Bailey. He's Professor of Allied Health, Sydney Local Health District, University of Sydney, a clinical psychologist. He's empathic, just even in my peripheral vision. He loves playing the game Mario Kart. I don't know this stuff, so if I get it wrong, but his favourite character is a mushroom named Toad. Now look, I didn't find that very encouraging. But I happened to be with him at the Women's Leadership Breakfast at the New South Wales Parliament this week. He was nominated by work colleagues as a supporter of women's careers. That makes me feel warm towards him. Professor Andrew Bailey.
Hi everyone. Systems and processes are the backbone of clinical excellence. With them, we can create excellent care and positive patient experience. Without them, care can be compromised. Isn't this a great event? What a great venue. What great catering we've had. What great speakers we have. And what a great team of organisers. Organisers, people who used systems and processes to make this event what it is. I'm going to concentrate now on the systems and processes and the experience of our staff in providing excellent care, excellent consumer experience, excellent health care for our patients and our community. Aren't humans wonderful? Here we are, mostly skinny, hairless apes. And we've come to dominate the planet. How did we do this? We went to the moon 50 years ago. We've eradicated smallpox. Aren't we cool? We even built robots that do surgery. Awesome, aren't we? We do that with systems and processes. We do that with careful research processes that help us extract the right knowledge, the right learnings out of experience. And one of the things as a psychologist that I found the most fascinating, I have the best subject matter to study. We are capable of the most amazing intelligence, the most amazing creativity, and yet Donald Trump is the President of the United States and not Hillary Clinton. Survivor outranks Antiques Roadshow. We have 11 million refugees in Syria. Humans are capable of these most amazing creative things. We're also capable of the most banal, the most destructive, the most pointless. Our challenge as a health district is to have systems and processes that celebrate and enhance innovation and creativity and protect us mostly from the careless and the distracted, but sometimes from the banal, destructive and pointless. So today I'm with Oscar Wilde. Experience is simply the name we give our mistakes. There he is, the great Oscar Wilde. Now, can I make this work? So, who in the audience here is trained to read chest CTs? Oh wow, not that many. Oh geez, I'm going to have to work hard on this one. Okay, who is experienced at reading chest CTs? Wow, okay, all right, we've got a problem then. Okay, now I'd like you to look at this one. And the task here is, can you count the cancerous nodules? Now, okay, I'm a psychologist. I'm told in these images there are 10. oops. My props aren't working for me. Can you spot anything unexpected? Oh, here's a technical problem. I can't read my notes. That was a rookie error. Okay, if you didn't see it, there was a gorilla in the chest CT. This is an amazing study done with experienced radiologists. 83%, can you believe that? Did not see that gorilla. Wow. I mean, gorillas in chest CTs, I grant it, are a serious health problem. But the point is, experience does not save us from cognitive biases. This is an example of what we call inattentional blindness. Inattentional blindness, where when you're looking for one thing, you tend to find it and you don't see other things that are unexpected. So, you've had this experience now. You've seen that, and you're probably never going to miss a gorilla in a chest CT again, are you? And you probably also learned that when a psychologist asks you trick questions, you should be a bit careful. Oh, Jesus, excuse me. We don't need a new Ministry of Health policy about gorillas escaping into chest CTs, but we do need policies and procedures in place that protect us from cognitive biases, that help us to bring out the learning in our work. Now, you may have heard that it takes 10,000 hours to make an expert. I'm here to tell you that that is rubbish. You can spend those 10,000 hours doing the wrong practice. You can get the wrong feedback. But you need careful systems and processes that help you to get the right feedback from the environment, to learn the right things. Again, it's the systems and processes that provide accurate and timely feedback for maximising learning. So, just to finish up then, from Oscar Wilde's perspective, experience is simply the name we give our mistakes. We need systems and processes to maximise how we can learn from our mistakes. Experience without systems will take our health districts to hell in a handbasket. Thank you.
Andrew? Ladies and gentlemen, I think if we could just put your monkey mask on, I think a few of us would like, I think Teresa would like a shot. And I again found his arguments utterly convincing. There was a very clear ape in that. But just... Sorry, but did you truly discover in real time that you couldn't see through your mask?
Yes.
That's absolutely
Complete
fantastic.
rookie error.
Thank you so much. That was really great. This is really hard, aren't they? They're both really convincing. The second speaker for the negative is Dr. Ruben Thanagassalam, a consultant urological surgeon at the RPA Institute of Academic Surgery and also at Lifehouse. Now, I'm going to tell you two things about Dr. Ruben that are actually true, that sounding, completely implausible, but honest to God, they're true. So Dr. Ruben, firstly, is the only member of the urology departments at Concord RPA and Lifehouse to have met Prince Charles, Prince William, Prince Harry and the Queen. I'm sorry, I find that impressive. But then they told me this. He's affectionately known as the Holy Urological Surgeon because he's the only urologist at the RPA campus to have operated on a patient called Jesus and a patient called Muhammad on the same day. Dr. Ruben.
Thank you very much for that lovely introduction, and lovely to see you all here today. Now, I was very impressed with, I think, am I on the label?
It feels very quiet.
Oh, okay. So thank you, Andrew, for your wonderful 6-minute talk, and I can tell that you're someone who's doesn't work in the trenches like us surgeons. So I'm going to give you my perspective of things, and I hope you don't get too offended. So it's very important to have, I'll go take it back to the argument. This argument is about, is systems and processes more important than experience, right? So there's no doubt we need systems and processes, but the critical point of this argument is it more important than experience? Now, obviously, there's a lot of, and I'm going to talk about surgery because I'm a surgeon, there's a lot of similarities between the aviation industry, the rail industry, and surgery. Clearly, we need to have systems and processes, but does it trump experience? So, for example, you've got a nice flashy plane there. Would you want someone who just reads the guidelines to fly in that plane? And when you've got to land the plane in a tricky situation in between mountains, you've only got one propeller, there's wind blowing everywhere, similar thing to surgery sometimes. Do you want someone who's just read the manual over and over again, or do you want someone who's actually got some experience of landing the plane in a difficult situation and can get that plane down without totally crashing it? Well, clearly, from our perspective, yes, you do. This is where experience counts. And similarly, when you're driving a train, and train driving is pretty straightforward, you just get in the train and you go fast and slow, and it's not that hard. And really, if you read the manual, you should be able to do it. And similarly, you think that in surgery, that's the same thing. But clearly, some people can drive that train heaps of times, but they still have issues. And that's the same reason why you need to have experience. You can't just have a train and think you can drive it. You need to actually know how to drive the train properly, because if you don't have experience, then you're going to smash it up. And sometimes you can see it happening even in slow motion, despite all the guidelines we have in theatre, despite all the pictures of Dr. Staley in the changing room about not going to McDonald's in your outfit, you can still have problems. So, surgery's been in practice since the beginning of mankind. Education in surgery is very important, and this is where systems and processes are very important. And the slide up the top there is a very delicate demonstration of surgery from Padua in 1428, where they basically get a hacksaw and carve someone up to teach the other people what the anatomy is like. Now, clearly, we've moved on from then, and you can see in the top left there that things have moved on, and this is a picture from 1800s in England, where they're demonstrating to medical students and doctors how to do an amputation on someone without an anesthetic. Fortunately, we don't have those problems anymore. As you know, I'm involved in robotic surgery. Nowadays, we have a robot, we sit on a console, and we have 3D vision. We look at the patient's insides, we do the surgery, everything's very controlled, people are relaxed. We know that there's systems and processes, we respect them, we work as a team, but obviously experience counts, because when things go wrong, that's when you need to have experience. And you can see here, everyone's very relaxed, there's no blood flying around, people aren't tearing around looking for blood transfusions, it's all under control. And similarly, going forward, and this is what we're involved in research at the Institute of Academic Surgery and at Sydney Uni at RPA, is actually the next step, which is what we want to do, is artificial intelligence in surgery. And again, you can't just turn up with some guidelines and expect to do things like this. So this is a kidney cancer operation with a tumor, and what we're involved in is actually doing 3D reconstructions of CT scans and then superimposing them on the robot, and then to identify the lesion, and then basically to dissect out the tumor itself and preserve the rest of the kidney. And this is very delicate surgery, and again, this is where experience counts. My experience was training in 2 years in Paris, and then when I got back, we started up at RPA. So we did hundreds and hundreds of cases. The French are a bit funny. Sorry, Jeremy, my fellow's here, he's from France, so I apologize in advance, but they don't like systems and rules, but they like experience. So coming on to my last slide, why is experience more important than systems and processes? Now, I'm going to show a little bit of a gory video, so if you don't like to see it, I'd recommend looking away now. But when I got back from France in 2014, I was asked to help a colleague who is working north of the river, so not in the SLHD, and he was planning to get an assistant to assist him with all his robotic surgery who was a GP. Now, GPs are excellent, and you have some GP assistants, but this is a case where he actually asked me to give him a hand, and I was the assistant surgeon, and he accidentally pulled that needle into the external iliac artery and lacerated it, and luckily I was there assisting him. Now, you can see very quickly that things go pear-shaped quickly. Now, luckily I was there, and you can see here, all of a sudden the camera got covered with blood, but because I'd been trained and as experienced, I knew exactly where to put those instruments to control the situation. So this is the main artery to the patient's leg. I put the clamps on, got control, and you'll see in this video that we sutured everything up. Everything was beautiful at the end, checked all the pulses, got the vascular surgeons in. The patient made a full recovery, was discharged home on the third day. Now, clearly, if you don't have experience and know what you're doing, and you're depending on guidelines and processes, then this situation could be very, very different. You'll see the end. But I would like to say that's my end of my
Thank you so
debate.
much.
Thank you.
Thank you so much, and just a reminder, I'm just giving one bell at 5 and another at 6.
That's
I don't
all right.
mean to interrupt you. Utterly compelling and convincing. This is going to be very, very hard for the clapper-meter, but don't worry, it's a wonderful piece of technology. Now, the third speaker for the affirmative, Associate Professor Mary Haynes from the Sydney Local Health District Board, 20 years senior executive experience, a PhD in Public Health, University College London, a former Fulbright scholar, and a current senior advisor to the Sachs Institute. Thought I should let you know who's on the board. She's credible. Mary was only average at school at sport. In fact, she says she only ran middle of the pack, but she made up for it in 2 ways. One, excellent at handball. She may bang a ball against the back of the room while she's talking, and she ran discos at the back of the school bus. So, a funster, Mary Haynes, make her welcome.
Thank you, Julie, and thank you for everyone here today. Here on the affirmative, we are arguing strongly that systems and processes are the backbone of clinical excellence. With them, we create positive patient experience, and without them, care can be compromised. So what have we heard from the opposition here today? What have we heard? Well, a good thing I brought along my magnifying glass, because with this I'll be able to find a skerrick of substance in their argument. Now, what can I see over there? What can I see? I think there's 2 lines of arguing I've heard over there. First is from the first speaker, that there's this false dichotomy between innovation and research and positive outcomes. Completely false dichotomy, because you wouldn't be conducting your research and publishing in the New England Journal of Medicine if you weren't embedded in a system like RPA where you could conduct research with good research and clinical governance around you that's safe for your patients to be involved in that research project. The second argument we've heard from Dr. Robot is this idea that, again, another false dichotomy, that you've only got automatrons that use clinical guidelines and processes to do clinical care, or these wonderful people that are experienced, and they throw the handbook out and just do what they think is best. Now think about those trains with those drivers who can stop errors and make mistakes. I think the member for Weeks can tell us that the Sydney Metro is now run by driverless trains, because we know that driverless trains are better than other trains. Moreover, Dr. Robot himself might have wonderful experience in Paris and do the most amazing surgery in our district. He has to go through systems of accreditation constantly to judge how good he is at his job. So whilst that experience is most definitely there and important, it's the system that gives us comfort about it. Some might say we've not heard from the member for Weeks. You may have heard her debate last time. She spoke a lot about her own personal and varied experience with the health system. So I suspect we'll hear much of the same. So to the member for Weeks, with apologies to Oscar Wilde, to go to hospital once might be regarded as a misfortune. To go twice looks like carelessness. And to go more than that, my dear, looks like a compulsion. Now, moving on to my argument. If there's one example that really highlights our argument today, it is this medtech scandal that's raging in the United States at the moment. The story of Elizabeth Holmes and Theranos. Many of you will know this story. It's complex. I'll pick out the strand that relates to us today. In mid-2004, Elizabeth Holmes dropped out of Stanford to set up a company called Theranos. What she wanted to do was to be able to provide tests for patients with just a single prick of blood that was going to be then put into the Edison machine to test people on a raft of tests. Now, who wouldn't want just a little prick of blood rather than go to vampire phlebotomists? Me. Everyone got behind this. She was on the front page of Fortune. She had a 4-star general board. All sounds very worthy and fantastic. The coup was she got a contract to put all these Edison machines into all the Walgreens pharmacies in the state of Arizona. Then something happened. October 2015, John Carreyrou from the Wall Street Journal landed an expose. All those Edison machines that were in the Walgreens in Arizona were not actually able to conduct the tests. They were flying them out somewhere. They also had contracts with the Centers for Medicare and Medicaid. They went in and started investigating, as did the FDA that had only given them one licence. The FDA withdrew their licence, and you can see here this quote from the Centre for Medicare and Medicaid, that the facility did not comply with the requirements of the performance and standards, and that it was an immediate jeopardy to patient health. So I think what this story tells us is that effective processes and systems were not at the heart of Theranos. They weren't at the backbone of that company. They were so focused on improving the patient experience and relying on the Edison machine and Elizabeth Holmes, who modelled herself with her black turtleneck on Steve Jobs, that they knew best. She had over $5 billion worth of investment, including $100 million from Rupert Murdoch backing her. Everyone got into this idea that she was great. How would you feel if you were a Walgreens customer and you were told that you didn't have a disease that you actually did? I put that to you, and that's what systems and processes protects you from. So in summary, our argument is that systems and processes are the backbone of clinical excellence, and without them, care can be compromised. There are other luminaries that support our point of view. For example, Willy Wonka. His chocolate factory might have seemed to be all about experienced chocolate rivers, everlasting gobstoppers, but mark my word, he ran a tight ship, systems and processes. Do you remember when Augustus Gloop drank from that chocolate river? In marched those Oompa Loompas to protect that chocolate factory from its rigorous systems and processes. I think we should call the internal audit reports here in the district Wonka reports, and I think Catherine Moore should think about calling herself the Chocolate Factory instead of the Centre for Clinical Governance. And finally, the last luminaries who would support our view, the Rolling Stones. Now, you might think these guys are pin-ups for the opposition, a group who are legends with their love of excessive experience. But even these guys, yes, even these guys know that you can't always get what you want. You can't always get what you want. No, you can't always get what you want. But if you try sometimes, you just might find you get what you need. Thank you.
Thank you so much. That was incredibly entertaining and pertinent. And let's all be grateful, because Mick, as you know, had some heart difficulties. I'm just remembering because I'm a baby boomer. He's back dancing on stage 3 weeks later. There you go, Mick. Okay. Third speaker for the negative. First of all, can you give them all a round of applause? This is going so well. Our third speaker for the negative is Victoria Weeks, Acting Chair of Sydney Local Health District, a lawyer with 30 years' experience in the financial sector. Victoria has 2 daughters with the same birthday, but they're not twins. This is like those questions to get into selective schools. I didn't make it. 2 daughters with the same birthday and they are not twins. Victoria is a very organised woman.
Thank you so much, Julie, and look, thank you, great debaters. Thank you, Team Negative, for allowing me to join you in this great debate. Like all good board members, I am blessed by the fact that I can actually ride on the coattails of my esteemed and highly skilled clinical colleagues. It's something I'm well accustomed to as a long-time non-clinical member of the Sydney Local Health District Board. And look, can I say my colleagues have articulately, insightfully, and with laser-like precision, actually especially in the robotic surgery, laser-like precision put the case for the negative, that clinical processes and systems are not more important than experience. As my esteemed clinical colleagues have pointed out, processes and systems are mere empty vessels, repositories, not suppositories, repositories, frameworks, shells, maybe even backbones, into which the richness of clinical and patient experience flows to provide meaningful and positive patient outcomes. And I love the backbone analogy because it's all very well having a backbone, but if you've got nothing else to go with it, there's not much left. So, now the affirmative have tried to confuse you. I actually think they've done a pretty good job, don't you, in telling us why experience is so important, but I'll give them some credit. They've also tried to distract us with the flashy mask. I have a prop, it's not pink, but anyway. But let's get back to the simple truth. Experience is both individual and collective, it's adaptable, it's evolving, it uses evidence and insight that we get every day to build our capability, and from our patients, our communities, really to provide that tailored care. So that's what experience is. And the title of this fabulous week of innovation could not be more on point. Imagine, transform, lead and experience. And as fabulous as the organisers are for this week, which they are, if we didn't have the experience to populate it, we wouldn't really have a symposium. Now, Ruben provided us with great examples, not only for his own work. I did actually close my eyes while that video was running, but from other industries like aviation, and no better case that we've seen most recently with the Boeing 737 MAX 8. They had a foolproof system, so they thought. They had the procedures that the pilots could read, but they decided not to train them, and sadly with really tragic results. So you can't possibly rely on systems totally. Jody's work in the cardiac genetic disorder areas is a great case in point, with sudden cardiac death in young people. If there's no procedures or protocols known, bad luck, whatever. But no, they keep looking and try to understand and use that experience. My job as the third speaker really is to just make it clear that all the arguments put by the affirmative don't make any sense. I say I'm really struggling here, apart from the backbone thing, because Jane quite rightly pointed out patient experience is absolutely critical to the work we do. So thank you very much for that additional argument to support our case. I think also, apart from the pink gorilla mask, I'm not sure what else to say about Andrew's case, but I can't let this opportunity go by without acknowledging my esteemed board colleague Mary Haynes, and say something about Mary. Mary's actually on the Audit and Risk Committee, which is fantastic, but it's unsurprising that she would support processes and systems. And I like processes and systems, and I value enormously Mary's contribution to the board, and I've mentored her since she joined just a few years ago, and she's showing great promise. Now, Team Negative has already given us the clinical examples that demonstrate why processes and systems are not more important than experience. But let me provide you with a board perspective. As most of you would know, I have no clinical experience except the odd visit to hospital. I'm getting over that. But my work experience comes primarily from the banking sector, and now as a board member across many organisations and sectors. And those who know me well know there's nothing I like more than a good process and system, but I know their limitations too. And of course, the banking sector, as I said, sort of proved the point if anyone was in doubt. So to bring the point home, let me give you a brief insight, a sneak peek, as it were, into the secret world of board governance in the health district. We have an inordinate number of processes, procedures, guidelines, checklists, attestations, KPIs, metrics, and that little pile over there is just the tip of the iceberg. Those are my props, just a few folders to show you all the processes and systems that we have to put up with. And every time something goes wrong in the system, there's another checklist, another attestation, another procedure, trying comprehensively to cover anything. Don't get me wrong, I believe in boards and good governance, and I think we do kind of an okay job, but here's the big secret to good governance: letting you do your job. When we on the Sydney Local Health District Board want to understand what's going on, we ask you, we listen to you, and that includes all our staff, our partners, our patients, our communities. We listen to those who have the experience, we understand the experience, and we use our experience as a board to make decisions. And in closing, as acting chair, on behalf of the board of the Sydney Local Health District, I really want to take this opportunity to acknowledge that it's the breadth and depth of your experience as staff, your insight, your imagination and commitment which makes the district so great and which makes our job as a board so easy. Thank you.
Well, ladies and gentlemen, you have got a difficult task. Let me introduce you to the clapper meter. In a second, I'm going to ask you whether you are going to support the affirmative side or the negative side, and the clapper meter is my arm. I respond to your noise. So if you make a lot of noise, my arm goes up. Do you understand? It's fairly technical, but we're going to rely upon it. Before we begin, because these 6 people have done a Trojan job, and it's not an easy thing in front of a big crowd like this, would you please congratulate both the affirmative and the negative teams? And I actually need to swap hands for this, but anyway, if you wish, don't worry about it, this is going to be the clapper meter arm. If you believe that when it comes to this debate, you have been utterly convinced by the affirmative team, start clapping now. Thank you very much. And if you believe you've been utterly convinced by the negative team, start clapping now. Well, I think that made my job just a little bit easier with the clapper meter. Look, this is a whole proper trophy with names on it and everything. I love it. Could I possibly ask you to, well, let's all cluster together, will we? Let's all cluster together because there's a lady with a camera. And can I ask you to hold that? And if I'll just stay in the middle just because I'm a glutton for it. Come close, everybody. We're all in together. If we squish, we should all fit. Thank you so much, guys. And we'll get one for just those ones, eh? So, ladies and gentlemen, a huge round of applause for our debaters.